very much, this is very much a situation which from a medical legal point of view comes up commonly. You can see here a picture of the eye. So the eye anatomy, we're probably pretty familiar. You'll see a pupil, which is the dark spot in the center, which is where the light comes in. The eye works a lot like a camera. So light is focused through the eye to the back of the eye. And if you look at the cross section underneath, you'll see that there's a clear window, the cornea at the front, and a lens behind the iris. And those two together focus the image on the back of the eye. There's a sweet spot for vision where you get your detailed vision called the macula, which is part of the retina. And I'm sure some people have heard of macular degeneration, which is a common disease where that becomes unhealthy with age. And the optic nerve is the cable which connects the eye to the brain. So like a camera, which is a digital camera, you see there's a cable connecting it to the brain where you have your computer or the visual cortex. Now,
sorry, Michael, I can't see your screen anymore.
Oh no, so it didn't, have you got the picture of the eye or not?
No, I've just got blank screen with your name on it.
Okay, let's try again. So don't know why that happened. The meeting is being recorded, got it. I'll share content again. Let me just try that. It's important because it's all based on pictures. So it should be coming up now.
There we go. Yep. Now I'm seeing the screen.
Right. Sorry about this, guys. So I'll get back onto the slides. Okay, now it's coming up. Now, can you see that picture?
Yes.
Great. Okay. And then the next picture. So if you missed it, I'll quickly show that. So I apologize if that wasn't up, but if you heard what I said, essentially that's an eye like a camera with the light being focused in the back. We're going to get straight onto some pictures and
oh dear.
Yeah, nothing's terrible. I'm going to apologize in advance if you find you're a bit squirmish. This isn't meant to shock. It's actually meant to be important and it's not too gory, but there's a few things that, you know, help to see. And so this is a young boy who came into our care at the end of last year. And he, as a few had done, actually had a hook go through his eye, but not a fish hook, but the hook from a clothing rack in a large department store chain. And this did actually make the news because a couple people had this happen. And unfortunately, and not uncommonly, when the lid gets hooked, it gets ripped apart. And you can see that there's a very complicated laceration through the top lid, which is very important for function to repair the contour. It's a sort of zigzag shape. And you'll see close to the nose, there's a line, and that line there has gone completely through the drainage system for the tears in the eyes at the top and actually had completely disrupted that tiny, tiny passageway that takes the tears away from the eye and it drains into the nose. And so if you pulled that tissue, the whole of that eyelid would come to the side. So ocular trauma with eyelids in kids, very common. And as you can see, very complicated, but we can do a good job at repairing. So I'm going to focus not just on the trauma, but how we fix it. So you can see what that means for patients if they've had similar presentations for your experience. And what you're looking at there is putting a very fine probe through into the system that I mentioned drains the tears. And there's these tiny passageways that open up into what is labeled as the lactamal sac, and it goes down into a duct and opens into the nose. And on the bottom left, you can see that there's these little cannulas that I use for fixing watery eyes as well as to repair. So when I was able to find the two ends of that pipe, which are about 0.5 millimeter big, so it's all very fine stuff, we can connect it, but it's too small to suture. So we put a wire down that keeps it all in place, and then it heals up and you can pull the lid together. And this is what he looked like after the repair about a month later. So he came back to theatre to get some other suture material resolved, and you can see on the inside of the eyelid there's a bit of a scar. On the top of the eyelid there's a bit of a scar, but it's obviously a lot tidier than it was before, and it's a very very amenable tissue to fixing up. There's a rule in the hospitals that eye doctors look after the plastic surgery of the eyelids because it's so intimately related to the function on the front of the eye. And you know, we are able to do pretty much everything that you need to do to repair the eyelid. If someone had this as a medical legal case, the AMA Guides to Permanent Impairment version 4 is the particular standard that we follow. And if you have scarring of the eyelid, then you can add up to 5 to 10% impairment for the visual system just based on the disfigurement. And there could be other issues with tearing of the eye or watery eye afterwards. Now, this is a situation which is all too common, unfortunately, where you can see on the left there's a trauma being perpetrated with a fist to the face, and this can happen from fists and knees and anything you can imagine. But you'll see that when that trauma happens to the bony cavity, the orbit, there's big air sacs around the orbit, which actually almost act like inverse airbags. So we have sinuses which help us in terms of the way we make sound and speech, but the sinuses are also there in a safety mechanism for the eye, because if anything goes to traumatize the eye, then the fracture blows out into those open spaces. So if you go on to the right-hand side of the picture, you'll see there's a normal orbital section through the right eye, which is the actually looking at the patient. So you'll see on the left, but on the other side, you see a bit of tissue prolapsing through the floor of the orbit. And that's important because the muscle can get trapped and you can have problems with not just the eye being sunk back, but also not being able to move because the muscles get trapped. If you look at the middle picture, then you can see someone who's obviously got a contusion around the eye, bit of bruising around the eyelid and on the eye. And that's someone who's trying to look up. You get the very distinct impression that the eye is sunken back because it's not sitting in the normal position because there's been a fracture in the socket, and the muscle is trapped down the bottom and they can't look up. So very often in these cases, it depends on how much of the floor is fractured, and obviously the globe injury that goes with it as to how we need to go about repairing it. In this situation, clinically in the middle, then that's a definite case to repair. And sometimes if the muscle's actually trapped in the fracture, the muscle itself can die. So we have to do it as an emergency. Otherwise, you may wait till the swelling goes down a week or two, and you can do something like this, which is shown most clearly on this skull section. And you can see on that side, on our right or the patient's left-hand side, there's a steel plate fixed. So you can actually make an incision either through the bottom of the eyelid or on the inside of the eyelid, and you can release the contents from that fracture. You can put a plate down the floor of the orbit, and then that will support the tissue. That's ultimately extremely successful, but as you can imagine, in terms of how far back you're going in the orbit, very, very challenging surgery to do. And then afterwards, if the patient does have some double vision or some problems, then certainly we can do something on the muscle itself around the eye to help with that. But very common indeed is a blowout fracture, basically because it's designed to be the way the eye works to save itself. So this is a similar sort of situation in terms of trauma. And if you look at the photograph on the top in the middle labeled B, you'll see somebody looking back at us, and obviously contusions and bruising around the eye as well. Looking at A, looking onto her right or our left, as we look at her, you can see that the eyes move normally. They move up normally in C, but in D, you can see that she can't move her eye out to her left or to our right. And that's because there's a damage to a muscle because of a nerve injury. And there's one particular nerve to one particular muscle that moves the eye out. And then in that case, it's very important. We always look at patients who have a palsy like this or a weakness in the nerve with neuroimaging, because that can happen because of a tumor or something new running on the nerve. But in this case, obviously from direct trauma. And strabismus is the word for turned eyes or eyes that don't work together for moving around. That can happen very commonly in trauma, again, either directly damaging the muscle, but importantly from the neurology as well. And we can do lots about this as well. So you can see an operative picture there where to fix the strabismus, you don't take the eye out. We open the eye with a speculum, which is a wire you can see opening the eyelids. We can rotate the eye to the position. You get a sense of the muscles which act like straps around the outside of the eye, and they move the eye up and down and side to side. And there are also some oblique muscles to rotate the eye. And if we've got a patient who's got an eye that is having trouble moving or working, we could do something to literally move the muscle like a wheel alignment. So you can see there's a suture going into that muscle, and we can then take that muscle off the eye, move it into a different position on the eye to make the eye straight, while also being able to still make it move or look around as it should be. On the picture on our right-hand side, as well as moving muscles, you can, what we call is transpose muscles, or move part of a muscle. In that picture before with the lady who couldn't move the eye at all, no matter what you did with that muscle, you wouldn't be able to make it work better if the nerve's not working. So we can actually move some of the other muscles to help essentially mimic the action or straighten the eye. And as complicated as it looks to do that, the results are actually outstanding. So you can very much effectively straighten an eye. Again, medico-legally, having double vision within the central 20 degrees is so disabling for people that it's considered on the AMA Guide 4 to be loss of the eye, which is 25% visual system impairment and 24% whole person impairment. So double vision or strabismus means that people can't drive, they might not be able to work, and it's just a real pain. So we do everything we can to fix that, but that can happen. These are some more dramatic pictures as you can get down to the really gory stuff. And I was talking with Michelle before, some of you might have heard that, yes, everything that you can possibly imagine can go into an eye. There's a metal wire that's going into someone's cornea, and you can see that it's quite cloudy around the cornea, the clear window, which is now losing function for that reason. There's a huge infection risk with this, let alone trying to repair the eye and put it back into normal. And a horrible photo of a fish hook going through an eye, and you can only imagine what it is like to try and take that out. But quite remarkably, a lot of these things can be repaired. There's a very different situation here in some ways with the perforation, because you can see, as well as just cutting the cornea, there's tissue from the iris plugging, and that happens very easily because that's essentially nature's way of sealing the eye. So before there were eye surgeons, there was nature, and nature would take its course in terms of a penetrating injury to try and plug the wound, and so the iris tends to come out, and you can see that what we call a peaked pupil. It's a funny shape, and that brown stuff coming out of the wound is just the iris, and we surgically would very carefully try and replace that tissue, try and save that tissue, and then repair the hole. And so again, a very common, in the last month I've done 2 medical legal reports on steel fixers who've had wire go through their eye. And unfortunately, inevitably, when there's a cut, there's a scar. You can see here what it looks like when we're doing a repair. And then on that left-hand side, as we look at the screen, there's a laceration, which just looks like a cloudy streak, but the first stitch has gone in. You can see that the pupil is round, and at the end of this, you see a line of sutures which go through. And in fact, at the stage that the second photograph is taken, this is a healed situation with a corneal scar, and there's a couple stitches that have already been removed. So we don't leave the stitches in permanently. They're a foreign body too. We can get less scar tissue and less optical problem from that. But if you damage the cornea, no matter how well you repair it, if it's anywhere near the central cornea, it will have an impact on the vision. Sometimes the trauma is simply a blunt trauma, and you can see what we call a high femur, or a blood level in the eye on our left. That can settle on its own. The body's good at circulating that blood out of the way, but we're very careful to keep the patient rested to stop a rebleed. But it's obviously much more significant in the back of the eye. And the photograph on our right, as we look at it, is showing a retina, which is that film at the back of the eye. And it's something I suppose you can't really appreciate so much from the photograph, but the hole in the back of the eye is where the nerve should be, and the nerve has actually been pulled out of the back of the eye. So that's a massive blunt trauma. I've seen this myself when a child fell off a 3-story balcony and landed with such a force that the concussion actually and the deformation force pulled the nerve out of the back of the eye. People in motor vehicle accidents with a whiplash injury can, by a shearing force, cause a diffuse nerve injury, even if the nerve's intact as well. Now, under the iris, we're going further back in the eye, we can see the way the lens can get affected with trauma. The first picture on the left is a cataract, and They don't all look this beautiful as a sort of star picture, but it's a good representation in terms of it's very clear that there's a cloudy patch in the pupil. The second picture in the middle is a rather more dramatic presentation because there's been such a blunt force that the lens has actually popped through the pupil and ended up in the front of the eye. And in this last photo on our right, you'll see that the lens is fallen down or dislocated inferiorly. The lens is suspended by these really fine zonules. It's like a capsule with a tissue. We operate on cataracts, and I'm sure everyone's had experience with someone they know or in their family having had cataract surgery. It's almost taken for granted, but it's extremely fine microsurgery. The capsule that we operate on or we leave intact with that surgery when we evacuate the lens material out is 3 microns thick. So there isn't a very large margin for error in our sort of line of working with that sort of surgery. But again, very commonly done. And you see here, this is the sort of lens that I'm talking about. The finger is supporting an intraocular lens very much like the sort that we put in people's eye. And as you can see on the side there on the right, there's a lens actually in the eye with a dilated pupil. There's an optic in the middle, which takes away the loss of focusing power when we take the lens material out. The material and the quality of the optics is outstanding now. Very rarely do they opacify. I actually, again, had a medical legal question asked about lens opacification. There has only been really recently one particular lens that's ended up over years going cloudy on its own due to a calcium deposition, but otherwise they stay clear for life, and it's incredible. And those little arms, haptics supported in the capsule. You can see a little bit of an opening in the middle where we've opened the capsule at the front to put the intraocular lens in. Interestingly, this technology in its infancy has been around since the Second World War and was first introduced because Dr. Harold Ridley was a Royal Air Force surgeon, and he noticed that the Spitfire pilots who were getting PMA, which is a special acrylic, from their windscreens in their eyes after having the windscreen shatter from the trauma of war, would actually not have a reaction or not have a inflammatory reaction to that material. And so quite rightly thought that this could be something that was used to then replace a cataract. And that's how it all started. And the instrumentation that goes with that and the lens material got a lot better. Nowadays, instead of a rigid lens that goes in with a large incision, when I do cataract surgery, and I've done it, of course, in my line of work on everything from 5-week-old to 95-year-olds, and the incision that we make to put the lens in the eye is 2.4 millimeters big only, because we can fold the lens, which is why it's such a common surgery. Now, you would have heard of possibly heard of glaucoma, which is an abnormality in terms of nerve damage from essentially pressure in the eye. Again, no need to go home with a degree in any sort of eye anatomy, but you can see what's shown there is a cross-section of the eye, and the lens that we've just been talking about behind the iris. Fluid's actually made in the back of the eye, and it circulates to an angle in the front of the eye. And what they're showing there is that you can actually, if you have pressure in the eye which is too high and it's squashing or damaging the nerve, make a little flap that lets the fluid gently percolate out, and then that will lessen the pressure and the damage to the nerve over time. You might imagine if you put your arm over the back of the chair, the nerve in your arm gets pinched, and then there is a sort of degeneration or a nerve injury that happens from that if you left it there for the whole of Saturday night. And in terms of the eye having a nerve in the back of the eye with pressure on it from the pressure being auto-regulated in the eye incorrectly, then that can happen, and that's called glaucoma. On the right-hand side, as we look, you can see that there's a tube, and you can actually as well literally stick a tube in the eye to let the fluid percolate out into a plate under the lining of the eye on the outside. Glaucoma is very important because it's a peripheral vision or an outside of your vision loss. It can happen very slowly and sneakily. I had a patient walk into the eye hospital once who was in his mid-40s. 20 years ago, he'd had a motor vehicle accident, had lost one eye. Unfortunately, he hadn't been told at the time that because of the concussive injury, there's a lifelong risk of glaucoma to the other eye. And he only turned up when he couldn't see in that eye, and the glaucoma had actually meant, unfortunately, he'd lost vision in his remaining eye, which was entirely preventable if he'd been educated at the time that he could have just had an annual pressure check. Now we're getting to the end and the end of the eye, and you're seeing in here some photographs of the retina. The white disc is the optic disc or optic nerve in the back of the eye, and the curtain coming down on the photo on our left-hand side is a retinal detachment. And you see that happen, and patients describe that as a curtain coming across their vision. In the central photograph, just very uncommonly, but more easy to appreciate, it's just a tear or a hole in that tissue. And on the right-hand side, that big black streak is metal. And so foreign bodies or trauma can very commonly cause problems in the back of the eye, of course, if there's a penetrating injury where there's material or damage in the back of the eye. The retina is a permanent tissue. You can't replace retina. You may be able to reattach it. We can put gas or oil or fluid in the eye to tamponade or push the retina back into place to restore anatomy. But it is, in essence, a much more tricky injury. And if there's been a trauma where the retina has been damaged, then the chance of there being an effect from that is almost guaranteed. And then you can see here the sort of way that we get to do that is by putting instruments in the back of the eye. And the diagram there on the side shows you do that with a light pipe. So you put a light in the back, you have a special microscope with then a view of the back of the eye, and you're pumping fluid in the eye, and you can actually, again, put gas or air or fluid and exchange that. And on the side that we see there, all those little things like a porcupine spine poking out of the eye, those instruments, and that's going into the back of the eye to do that sort of surgery. So at the end of this, we remember that the reason that all this is important is because in ophthalmology, it's not about, injury or anatomy, it's about function, and that means vision. So we're very much, of course, importantly thinking of that in every situation, and the picture's there to remind us that at the end of all this, it's not about what we see, but it's about how our patient sees. And so trauma is a part of life, and we are extremely lucky that we have in Australia in particular the support and the skills to do pretty dramatic things to help people from the situation. But again, from the point of view legally and medico-legally, when there's been an impact on vision, absolutely, it has a very significant impact on a person's life. And I think it is appropriately reflected and respected in terms of the guidelines for how we go about assessing that injury. So that's it. So I hope that wasn't too much or too confusing for anyone. And I hope that certainly was entertaining, but made some sense too. So Michelle, if you want to invite questions, if you can.
Absolutely. Can I just say that was fascinating. Thank you for those images, because they really did illustrate the points that you were trying to make, and made me, certainly as a person who reads a lot of IME reports, understand a lot more about your specialty and about the particular intricacies of working with eyes. But I also liked the fact that you spoke of not only the technicality of doing the task that you do, but your belief in the importance of sight to people. And that's sort of just really kind of lovely to hear as well. Anyway, so people, anyone like to ask a question? And silence. Now, can I tell you, don't feel bad about that at all.
No, I mean, they all understood it.
Often the ones where we don't get questions, people are kind of blown away, and then afterwards I'll get, oh my God, that was amazing, or we'll get, wow, and that sort of thing. I wanted to ask a quick question of you. When you're looking medico-legally at those traumatic eye injuries, are you ever asked to look at causation, or is it purely the extent of the injury?
It's a situation where actually it's both, but in trauma, the causation is usually very, very clear. But then there's many times actually where the trouble goes on to patients experiencing symptoms which might be out of keeping with that trauma or with their with their situation clinically otherwise. So from that point of view, it's under the there's sort of circumstance where the more severe things, you know exactly what to do, and it's very clear and there's no questions. And I do see people that have had a wire in the eye and it's like no questions asked, easy to say, yes, you've had this happen, and there's no surprise that you can't see. It's much more difficult when someone says they opened a cleaning product 20 years ago and now they can't open their eyes again because of dry eye and glare. And you do unfortunately have people who perhaps are looking much more for a reason to have problems with their vision. But yeah, so that's when the causation comes into play. So it's easy when it's big stuff, and you've got to be very, very diligent about your exam and your sort of opinion otherwise. So
yeah. Amish has asked a question. Are there any early symptoms to look for in clients? Amish, did you want to expand upon that? Do you mean to determine whether you send somebody to an ophthalmic surgeon, or what is it, the context of your question there? Amish?
I saw the start of that question, because I think he was asking about the optic nerve injury and trauma in motor vehicle accidents as well.
Right.
So,
okay.
Yeah, I think if you have an injury, if you have an injury essentially from the optic nerve, it's something that you will have poor vision with straight away, and then you'll end up with poor vision later when you'd expect it to be normal. So the question was, you mentioned that nerve detachment in motor vehicle accidents. Are there any early symptoms to look for in clients? Well, certainly it would be that the injury to the nerve is instantaneous and they wouldn't be able to see, and maybe basic symptoms associated with optic nerve injury. Well, that sort of injury means that you can then lose function in the eye over time. So this diffuse axonal injury we see, actually I see more commonly in what we call shaken baby syndrome, which is a very special sort of trauma. Unfortunately, in children's hospitals, we see those patients who've had that inflicted from the shearing force of shaking. And other times I've seen it again, it's been a very severe motor vehicle accidents, and we'll look for a pale nerve over time, but the nerve will stop working straight away and they'll have poor vision later on. It might take many, many months for that nerve to look pale, and you might be looking in going, well, they say they can't see, but the nerve looks okay. And a year later, you say, right, the nerve now looks pale, and that's the reason why. So it's more subtle, but you go back to the vision. So what we assess there from a patient, obviously only otherwise, is a little bit limited by if someone's in ICU from a motor vehicle accident. We can't necessarily, of course, ever tell what they're seeing, or if they're a child. Again, very different.
Great. Oh, that's terrific. Anyone else has any other questions that they would like to ask? No? Look, that's awesome. Terrific. Thank you so much. That really was terrific, Michael. Really great. Are you okay with
their lunch? Yeah.
Are you okay with people getting a copy of the recording after this?
Yeah, I hope I can find it, and I'm absolutely very happy to share that. No problems. And as questions, I'm happy to answer if it comes through later. That's fine.
Oh, magic. Look, again, thank you everybody for making time to join us for this seminar. Thank you very much to Dr. Jones. Go and have a great rest of the day, everybody.
I will. Thank you.
Bye-bye.